Hey guys, so today I'm going to talk about how to think about and approach difficult airway calls for surgical residents. So, quick disclaimer, this content is for medical education purposes only and should only be done by trained professionals. You should defer to your supervising surgeon's guidance and instructions as well as your institution's protocols. So, in general, general surgery residents are often called to stand by for difficult airways in case a surgical airway is needed emergently. These are high pressure, high stress scenarios that can deteriorate rapidly. So, you need to be ready to perform an emergency surgical airway at any moment if the situation calls for it. Because it's so high stress, preparation and rehearsal and leadership are super critical in these situations. You need to be comfortable in all aspects of this situation, not only the operative technical skill of performing the cricothyrotomy, but also in having everything in place prepared ahead of time and knowing how you're going to approach the situation and decide if you need to act. You must rehearse in your mind how you're going to handle these situations. And a final caveat is that this applies to adult patients only. So the core principle in thinking about these situations is that your job is not just technical, as I mentioned earlier. Your job is to stabilize and direct the room if the time comes where you must intervene. Be prepared to assert order and take control of the room if a surgical airway becomes necessary. Some tips towards making that possible: maintain your composure, but if you need to intervene or if you need to ask and ascertain information, be clear, loud, and concise. Clarify the situation with the questions you need and insert yourself decisively if you need to. Prepare early, and once you decide to act, be decisive. So, in general, I think that this situation can be broken into four steps when you're thinking about how to approach it. First is the pre arrival mindset. When the call goes out that a difficult airway is encountered and they need surgery bedside to possibly prepare for a surgical airway, you want the senior surgical resident or attending to respond immediately. That resident should bring with them a 10 or 11 blade, a bougie, and a 6 cuffed ET tube. Or you should make sure that anesthesia already has the bougie and the ET tube bedside. If available, you want to bring with you a cricothyrotomy kit, as this will often already have all the helpful surgical instruments you need, such as retractors and a dilator. And while you're making your way to the scene, you want to make sure that the nursing team is getting suction ready and ensuring good lighting in the room. You yourself should try to bring some suture if possible, heavy silk suture to secure the ET tube temporarily. And then you want to prepare yourself mentally for this to truly be a can't intubate, can't oxygenate scenario. So at this point, you make your way to the bedside. Once you're at bedside, you want to announce yourself as surgery and that you're prepared to do a surgical airway if needed, just so everyone is on the same page as you as to why you are there. Then you want to head to the head of the bed to further assess the patient. At this point, I would also alert the attending to be ready at a moment's notice if needed to assist in obtaining a surgical airway, and just so that you have backup available if the situation deteriorates. Once you're at the head of the bed, you want to assess the patient. You want to assess their O2 trend. You want to look for if it's plateauing, if it's holding stable, if it's going up, or if it's declining. And then you want to ask the anesthesia team how many attempts they've made at intubating the patient. In general, you don't want to wait for more than 3 attempts at intubation. At that point, you likely need to intervene. But you want to clarify that number first. Have they started? Have they tried? What adjuncts have they used? What is their backup plan? How successful have they been? You want to just stay in communication so you know at what stage the situation is and how close to intervention you need to be. If they are failing, if they have made multiple attempts and failed, you need to be preparing mentally to intervene decisively. I would already have palpated the neck at the first attempt at intubation, and I would arguably have splashed betadine, or some sort of prep on the neck in anticipation of intervening as soon as possible should their second attempt or third attempt fail. So at this point, we are at step 3, decision threshold. By this point, you need to have gathered several pieces of information. Is the anesthesia team struggling, or have they asked for your intervention? Have they proceeded with multiple failed intubation attempts despite using increasing adjuncts, such as a senior resident or an attending physician attempting intubation? Is there continued inability to oxygenate by various means? Is there rapidly falling O2 saturation? These are all clues that you are in a cannot intubate, cannot ventilate / oxygenate scenario. Those would be indications to proceed with the surgical airway. Basically, I think the way to think about this in general terms is you should prepare to cric if the following are true, and be prepared to document everything afterwards justifying your reasoning. Specifically, you want to look for if anesthesia asks you to proceed with a surgical airway as they feel they do not have a safe shot. If the anesthesia team has tried several intubation attempts with escalating adjuncts and are not successful and the patient is desatting. If, on the other hand, anesthesia has made some attempts but is able to continue to successfully bag, mask, ventilate, and O2 sats are maintaining, you may actually have time to do emergent transfer to the OR for awake trach. But barring those circumstances and the saturation is failing, they've had multiple failed attempts, you're probably looking at a surgical airway situation. There's no set number of attempts in the literature, but 3 is generally the maximum you can wait based on some of the literature out there. And after that, once you have committed to the decision, you must clearly announce we are proceeding with the surgical airway. The number of attempts is not as important as the patient's physiology. Are they desatting? Are they declining? Do you have to have a lower threshold to intervene? Once you've made that decision based on the pieces of information you have, do not hesitate. Do not wait to be asked. If the patient is dying and the airway attempts are failing, you must make a call and you must act decisively. That takes us to the execution phase. At this point, you are committed to the cricothyrotomy and you must move decisively. You must perform the surgical cricothyrotomy per established technique. Once you're in, you must inflate the cuff and confirm bilateral breath sounds. And you want to confirm placement with ETCO2 and secure the airway and reassess hemodynamics. I have included links to 2 resources that I thought were extremely helpful for this. The first one is the Behind the Knife Trauma Surgery Video Atlas series. They have a very good video on cricothyrotomy and all the equipment you'll need bedside and how to do it. I thought it was a beautiful video. And then the second resource I've linked is the Atlas of Surgical Techniques in Trauma, which is one of my favorite books in all of surgical residency. It is not only includes illustrations on how to do the cricothyrotomy, but a slew of other trauma procedures, and it's really clearly written, very concise, and just a very helpful book. So some final thoughts. In these situations, they are very high stress, high pressure. There's a lot of people in the room. It's easy to become a passive observer in these situations. You need to have rehearsed mentally what you're going to do, what questions you're going to ask, and how you are going to decide when to intervene or not ahead of time so that you can manage the pressure and stress of the room. You want to be prepared and do early preparation as much as possible to help mitigate the amount of stress and pressure in the room. What I mean by that is you want to have your supplies already ready. You want to know where the cric kits are. You want to have some stashed away ahead of time. You want to carry a sterile scalpel in your pocket. Just anything you can do to mitigate the stress of the situation so that you know how to take control of the situation if needed and how to intervene if needed. You need to think about this ahead of time and think about what you will do. Decisiveness beats delay once you are committed to intervening, and you want to be as clear as possible about your reasoning and the questions you're asking. This is one of those situations where you will fall to your level of training and preparation, some kind of similar to how they talk about in the military. in high stress situations, you fall to your base level of training. This is a similar situation in my opinion. Technical skill matters a lot, as does leadership and being decisive in these situations. Good luck.